Center. It's our honor to be here today as cardiac surgeons, contribute what we can. Obviously, all the cardiology we know we learned from cardiologists, so we all remain respectful. I have to give you my best smile now, George. Are you ready? So we're going to be talking about TAVR explantation today. This is the fastest growing field in cardiac surgery. If you look at the STS database, as a percentage rise in cases, this is the fastest growing case in the field of cardiac surgery. So what we'll discuss today, TAVI cases and indications are rapidly expanding to include a younger and healthier population. We'll discuss the indications for TAVI explant, surgical method of TAVI explant, outcomes of the global experience of TAVI explant, as well as some of our cases at Hygeia, including new procedures to facilitate repeat TAVI, which are surplus and open basilica. So without any doubt, TAVI is the biggest development of the past 20 years in the field of cardiac care. We see everybody knows Cribier here, April 16, 2002. The patient didn't do very well. However, this did mark the beginning of the transcatheter era of heart valves. So nothing lasts forever. It's my favorite cocktail party trivia that a diamond, given enough time, will turn into graphite in billions of years because graphite is the most stable form of carbon. Something similar happens to TAVI. TAVI is also a diamond itself, but we think it degenerates a little bit faster into graphite or other substances. So this is an old slide from Danny Dvir, and you can see that there's a signal right around 5 years starting to develop. Obviously, we have a lot newer data than this. You can see this from JACC 2019, which Dr. Petronio showed at the ASC in 2020. And we see again, 5, 6, 7 years, we start to see a signal about SVD. And it's still a matter of debate and personal opinion whether TAVI valves last as long as surgical valves or not. But we have a couple clues about why that may not be the case. One of them is that crimping the valve tissue leads to damage. So when you look at a scanning electron microscopy image of the crimped valve compared to the intact valve, there's wrinkles, and these wrinkles are essentially damage that has occurred to the valve tissue. Another very important issue is that when you expand the TAVI valve, it doesn't always expand as they show you on the demonstration or in the video and the 3D animations that we've all seen, or when you look at it on the table when you're loading it. So depending on the configuration that the valve takes, we were just talking about bicuspid valves, depending on the configuration that the leaflets take, the configuration may lead to increased valve stress on the leaflet. So in TAVI, you're not removing the native leaflets, you're not removing the native calcium, so the valve conforms to the anatomy that's already there, essentially. This may increase leaflet stress. TAVI has its own set of complications. Here we see an aortic root rupture, embolization, which we also saw today in one of the live cases. These things happen. Thankfully, most of the time, they can be addressed in a transcatheter, non-invasive method. Here we have an aortic dissection flap that has occurred after a self-expanding TAVR. And obviously, TAVR can cause major aortic root injury. You see here a Gerbaud defect that was, again, caused by a TAVR. When we look at the Cleveland Clinic experience with TAVI explant, and this is only going back to about 4 years ago, 2020, 59 patients at the CCF required cardiac surgery after TAVI. They had an 8.5% mortality. And these are frequently multi-component operations with stenosis or regurgitation of the valve followed by perivalvular leak and endocarditis as the most common aortic valve indications for repeat surgery, with mitral pathology being the second most common cause. We see that the number of TAVI explants is increasing, and there's a decreasing time interval from the time of implantation to the time of explantation. When we look at the Michigan experience with TAVI explant, there were 48 reoperations between 2015 to 2021, reoperate rate of 5.9% out of 1,719 TAVRs, and they were most commonly TAVR explant and a need for mitral procedures. So as you'll see, the issue that comes up frequently is that patients have perhaps a moderate either stenosis or regurgitation of the mitral valve that with time progresses and requires a mitral procedure after patients had a TAVR. Very interestingly, when you look at the feasibility of whether a redo TAVR in TAVR was going to be possible at the time of the first TAVR implantation, the ability was only 51%. So when we tell patients get a TAVR, and if it fails, we'll just do a repeat TAVR in TAVR, that's only true half of the time. And there was a presence of non-aortic valve pathologies at index TAVR of 49%, meaning half the patients who are getting a TAVR in Michigan have another cardiac pathology that is being left untreated. And shockingly, I think the most shocking is this persistently high mortality of cardiac operations after TAVR, which is 15% in this series. We see some of the reasons here why patients were not eligible for TAVI and TAVI, usually anatomic reasons such as a low-lying coronary artery takeoff or predicted severe PPM with the first valve that's been implanted being small. TAVI explant in this series again rises with time, and we see that mitral pathology is the most common pathology besides aortic valve pathology for patients requiring an operation. Unfortunately, many patients who undergo TAVI explant will require concomitant surgery of the aorta. You see that 29% of patients required some aortic operation, not aortic valve, but of the wall of the aorta. So 79% required an aortic root repair, 43% required ascending aortic repair, and 14% required a hemiarch aortic repair. The numbers don't add up to 100% because obviously patients can require more than one of these. And then when you look at the STS database, I don't want to belabor the point, but again, there's an 18% 30-day mortality for removing a TAVR valve. This is very high, and there's no difference essentially between balloon expandable and self-expandable, aside from the fact that self-expanding, obviously, these are taller valves. They required surgery of the aorta more often, 22% versus 9% in the balloon expandable valves. As a surgeon, it's very important to look at the anatomy of these valves, and I think it's yet another reason why as surgeons we should be involved in TAVR, because if you put them in, you're more likely to know what you're going after when you take them out. So this is the aortotomy that you need to perform when you're taking out, on the left, a sapien valve, and obviously the aortotomy needs to be much higher when you're taking out a self-expanding valve, an evolute valve, and I can tell you from personal experience, it's quite high. These valves go all the way to the innominate artery almost. So technically it's a little bit more challenging. Transcatheter aortic bioprosthesis explantation, systematic review and meta-analysis of 1,680 TAVR explants showed a 30-day mortality of 16.7%, and again a need of 29% for some kind of aortic operation. Usually it's at about a year after the TAVR. So things such as endocarditis and paravalvular leak are obvious causes for an early failure. Surgical explantation after TAVR failure from the international registry, again, you can see that there's an increasing number of cases year after year. 2019, there were 72 explants, most of them occurring within the first year. Main indications in this registry for explant were endocarditis, paravalvular leak, and structural valve deterioration. PVL, anatomy, and patient prosthesis mismatch were the main reasons that redo TAVI could not be performed. So again, as I said before, this is something important to keep in mind when we tell our patients that they're going to have their first TAVI. They're young. We were talking about TAVR in young patients earlier today. We have to be sure that we're going to have something to offer these patients in 5 or 10 years when they come back for their second valve. Why? Because we can see poor survival after TAVI explant. So when we have discussions in the heart team about patients who are going to need 2 or 3 valves in their lifetime, and one of them at least is going to be surgical, we discuss, should the surgical procedure be done as the first operation? Should it be the second? Should it be the third? As a surgeon, obviously, I promote the fact that the surgical operation should be the first operation, followed by 1 or 2 transcatheter operations. And the reason is it's much easier to remove the native valve, put in a surgical valve, plus minus an aortic root enlargement, as opposed to having a transcatheter valve in there first. Then I have to go dig it out, perhaps do a Bentall or a BioBentall, and then we're talking about much higher mortality. This is the reason why, in an increasing number of editorials, surgeons and cardiologists are promoting the same idea. This is an example of a TAVI explant performed at Hygeia for TAVI, which was performed at another center and then didn't go so well, was sent to us. I was able to obtain the fluoro of the initial operation. So you can see here a heavily calcified annulus. It looks like the evolute is struggling. Efforts are made to reposition this valve. And here you can see clearly this valve is taking up about half of the annulus, right? So this valve lost to the calcium, essentially. An attempt is made to balloon this valve, but obviously we know that's not a panacea, and so this didn't go so well. So this valve has a paravalvular as well as a transvalvular leak, and I'll show you why when I show you what it looked like when we removed it. Yeah, it's infolded, and here's the CT scan of this patient. Look at the aortic root and look at what percentage of the aortic root is being taken up by the valve. So it's about half. So it's not doing so well. Patient comes to us with severe dyspnea, transvalvular and paravalvular leak, PA pressure of about 100. This is the chest x-ray, as you can see. So this is the surgical removal. Thankfully for us, it's relatively easy. When you get them early like this, it's relatively early. They don't all go as smoothly as this. This is a surgical removal of the evolute valve 30 days later. You can see we're exploring the aortic root to see whether there are any adhesions between the valve and the tissue of the actual aortic root and ascending aorta. Cold water lavage to help the valve fold in and become more conformable. We're using a number of pickups here, multiple people, to try and kind of recrimp this valve surgically. One last tug, and we get the valve out of there, thankfully, with any, that's the photo finish. So obviously you can see here prominent valve infolding. Look, it came out and you can see that it's folded in. Normally when you put these valves underwater, obviously under the weight of the water, all three of the leaflets are supposed to close. Putting this valve underwater, one of the leaflets remains open. So this is how this patient was living, with this one leaflet of the three non-functional. You can see severe distortion. I think when I spin it around in my hands here, you can see that this is what I was talking about earlier. When we talk about why these valves may deteriorate earlier, obviously this valve, lasted a month because we had to remove it. But if you have this valve and it's not in the proper configuration of expansion, even if it worked, this valve isn't going to last a long time because the stress on the leaflets is enormous when it's not in the proper orientation. This is the calcium we removed before we replaced the surgical valve. This was the enemy to which the evolute valve lost. Now, obviously, I'm showing you a case that's the very, 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 very minor minority of these cases, and most of the time this doesn't happen. But this is something that we keep in mind when we're looking at a CT scan and performing our heart team meetings. This is not a failure of the TAVR valve. I think this is a failure of planning. So I think we need to put it on ourselves as physicians to not have this happen. The evolute valve is a great valve. We use it all the time. But I think this was a case where the implanting physician did a disservice. This is the hospital course. This was an uneventful recovery. The patient's home 6 days later. Pulmonary hypertension completely gone, and normal valve function on pre-discharge echo. So now just a quick tidbit on new surgical procedures to facilitate TAVI. So we talked about the fact that only 50% of patients, at least in the Michigan series, are going to be able to undergo TAVI and TAVI. And why is that? Most of the times it's anatomic. So we have come up with this hybrid procedure, not ourselves, the cardiothoracic surgical and interventional cardiology community. So this is the surplus procedure for redo TAVR. So what's the surplus procedure? Basically, in cases where we're not going to be able to perform a valve-in-valve, we put the patient on bypass, clamp the aorta, small aortotomy, take out just the leaflets of the TAVR valve, leave the TAVR valve frame in, and then we're able to, under fluoro and direct vision, implant another valve. So this is our case at Hygeia. So this is a 92-year-old lady, diabetic, hypertensive, moderate lung disease. At age 86, she had TAVI with a self-expanding valve. And we said, okay, this lady, 86, no problem, she's done. She's already outlived even the Greek superwoman grandmother life expectancy, which is 83. And now she comes back to us with severe TAVI stenosis, moderate regurgitation. She's not a candidate for TAVI and TAVI. because the valve leaflets will obstruct the coronaries. Even if we use a chimney procedure, she just wasn't possible. We spoke with our good friend Vasilios Babeleros in Emory because our good friend Dr. Dangas was in the cath lab at the moment. And we said we will proceed with a surplus procedure. So this is what's done. I'm the operating physician here. Our anesthesiologist is taking the photos. Sorry we didn't have video on this one, but we were a bit absorbed to actually performing the procedure. So what's done here, you can see the aortic cross-clamp, and I'll show you on the floor as well. We've cross-clamped the aorta. We had to have a very high aortotomy, very close to the cross-clamp, in order to be able to see. We take rongeurs, and the leaflets of the TAVR valve are very calcified. We remove them, and after we've removed them, then at that point it's very easy. On fluoro here you can see all the aortic cannulas. You can see the cross clamp is what you're seeing at the top of the valve, so you can see how close the cross clamp is to the evolute valve. The other cannula is the venous cannula that you see on all the way on the left-hand side of the screen. So that procedure went well. Something else to help us out as surgeons, this is the open basilica procedure for failed bioprosthetic valves. So basically, what we've said as surgeons is that at times we're going to need to do redo operations on our own valves. So this is for surgical bioprosthetic valves. So when these degenerate, instead of digging out the whole aortic root, one possibility is again to remove the leaflets. Again, cardiopulmonary bypass, cross clamp, remove the leaflets, place a TAVR valve under direct vision. Most of the time we don't need to do this. And then I'm going to close with a couple words. We talked earlier today about aortic root enlargement, but when we look at this, it's always interesting to me when I see advertisements and I think about marketing and I think about companies and what do they talk about. Why is it that our good friends at Medtronic have this commercial that only one TAVI valve had better hemodynamics than SAVR? What's the reason for this? You have to really dig into it, and I think part of it has to do with this. When you look at the supplementary appendix for the partner trial, you see that 21 patients in the partner trial had aortic root enlargement, and that may have given the advantage to at least even things out, whereas in previous trials you saw TAVR having better EOA and gradients than the surgical valves. Here you can see a slight advantage both for gradients and EOA with the surgical valves. And I think, as I said before, our cardiology colleagues have made us better and have pushed us to really perform the best operation for the patients. So what's aortic root enlargement? I'll be very quick about this. Multiple different types of operations, Nix, Manugian. To enlarge the root, you put a patch in. Essentially, you open up the aortic annulus, and then you sew the valve partially onto your patch and partially onto the annulus. This is a nice valve. This is a nice video from Toronto. My anesthesiologist's taking the video over my shoulder. Don't make as nice a video as this. So I wanted to show you their operation. This is with a bovine pericardial patch. Basically, they've cut into the aortic annulus, and then they basically sew aortic valve in, just as we do always, but you can see that on one side you have this patch. This is aortic root enlargement at Hygeia. In the circle, you have the aortic annulus, and then you can see the strip of bovine pericardium being used to enlarge the annulus, and that strip of bovine pericardium is then also used to close the aortotomy. So I think that this is the advantage that we have with surgery, and this is something that we need to keep in mind in our heart team meetings when we're discussing whether a young patient is going to have a TAVR or a surgical replacement. In conclusion, I think that TAVI is a wonderful procedure for the right patients. We have to be very careful with patient selection and before performing TAVI on young, low-risk patients. TAVI explant is rising. It's a very complex and very high-risk procedure. Please keep this in mind when you discuss patients who may need 2 or 3 valves, that surgery should probably be their first operation. We should save the transcatheter operations for the second or third procedure. And this is, fortunately or unfortunately, the cardiac surgery specialty of the future, because the younger generation of cardiac surgeons are going to be seeing this in an ever-increasing proportion of our patients. Thank you very much.
Thank you very much, Greg, for your comprehensive sort of presentation. I think we're lucky because we've got a bit of time, because as Dr. Pitsis is not going to give his lecture. So I would like you to make one comment and ask two questions. First of all, about this, I understand that the explantation of TAVI is a difficult procedure. But what is sort of the numbers about the mortality, they look quite high, they a bit puzzle me because, first of all, there are very small numbers that are being performed. So we can have, we don't know, and apparently the experience of the surgeons is not high. So I hope that will increase. The second is that the majority of the cases that they needed to explantation was due to endocarditis, which is anyway, it's a very bad procedure for whatever reason. Yep. If you're going to do, it's not because of TAVR, if you do 50% of your cases due to endocarditis of surgical implanted procedures, that's going to be possibly higher. So I can't stand with that. And also, it caused me a bit of puzzle that although it would have been expected to be rather easier because the majority of the cases were in the first year, still so high. So I would say that the numbers that we say high is because of the endocarditis and not because of the difficulty of the TAVR explantation.
Yeah. So, may I make a comment on this?
That's my comment, but I would like to ask you.
Yeah. So I completely agree.
Can I make a comment?
You always, whenever you see these series, it's what you're saying is true. Most of these patients come from an era when it was only excessively high-risk patients who were being offered TAVR. So obviously they're older, they're more frail, they have more comorbidities. You're selecting a worse group, without any doubt. However, I think we shouldn't ignore the fact that 30% of them require an aortic root procedure. It's a demanding procedure, but Dr. Chamogeorgakis wanted to comment as well, yeah?
From the few TAVR explants that I've done, what strikes me is that the wire of the implanted valve is well incorporated in the aortic wall and sometimes penetrates the aortic wall. So you have to be very careful. You have to develop the right plane when you explant the valve. And I think from what you showed us, the associated procedures when you had the TAVR explant from the Cleveland Clinic, sometimes you inadvertently traumatize the ascending aorta, in which case you have to replace it. So this is another factor that you have to consider for the higher mortality of those cases.
Yeah. Anyway, what I would like to say is that these numbers are not, we don't know the numbers, how difficult it is, because they are for selected patients, for that they were very high risk to start with. They had a high risk pathology, which is endocarditis, and although it should have been easier because it was very not far away from the first implantation, that's what they are. So, but we have to see it. Another question is, I've always been a sort of a big fan of doing the surgical procedure first and do the TAVR afterwards, if you are going to have two procedures. But now with this open basilica, should this paradigm change?
So this open basilica is only for surgically implanted transcatheter valves. This open basilica is addressing surgical valves, not TAVR valves. Why? However, the surplus procedure is the one. So the surplus procedure is that one. I think when you look at this, it makes it somewhat complex, and we don't have. I mean, we had performed the first one in Greece. I don't know if another one has been performed, to be quite honest with you. The numbers are very low. The experience is low, so it's hard to propose something that we don't have a lot of data on. You're right that perhaps it's easy for me to cross-clamp the aorta, make a small incision, rongeur, and put in another valve. But it remains to be seen what's going to be the most low-risk strategy.
So it seems to me an easy thing, but we have to see. And the other question is for both of you. Why do we see so small proportion of root enlargement?
I'll let Dr. Chamogeorgakis take it because my answer is brief. But Dr. Chamogeorgakis, why don't we do this more often?
Why we don't do this more often? I think it should be done more often. It depends on the easiness of the operator. I think you should have a low threshold. If you don't have a big enough annulus, you should open it up.
Yeah,
but it's a simple procedure.
Why not?
Why is not being done? Why is not experience? Not enough.
I guess some surgeons are afraid, are a little reluctant to do it.
I'll tell you my answer. So here's my answer. It's multiple-fold. First, the experience is low. If you don't see it in your training program, where are you going to see it? I was in the US for 20 years. I saw 2 aortic root enlargements, 2. So it takes guts when you're going to do your first one to do something after watching a YouTube video or opening up a textbook. If someone has not shown you how to do this, it's going to be, it's difficult to make that jump. It's like bungee jumping here. The second is that we don't have patients and cardiologists demanding it. If someone walks into my door and says, you do this, or I go next door to another surgeon, we will do it. The same with a cardiologist. If you have a lady, and I always say the same example, if you have a lady, and it's usually women, who are short and especially obese, this is your high-risk population for having patient-prosthesis mismatch. So if you have a lady like that, and you're going to call myself up or call Dr. Chamogeorgakis, as the referring cardiologist, you should say, Greg, I have this lady, she needs an aortic root enlargement. Are you capable? Otherwise, I'm calling somebody else. It's Friday night. We have lots of options here in Athens. That's my viewpoint.
Anyway, I don't think that the right thing is to ask the cardiologist to ask what somebody has to be done.
I think it should be our call.
There is one more option, and that's the Percival valve. The valve which gets us out of trouble with such situations.
It has good the Percival valve has good gradients, it's true, and it's much more simple. I think it's much more applicable to the general cardiac surgical community. If you've never seen one done before and you have a small aortic root, we've used it before in high-risk cases or in complex multi-component cases. I think the Percival valve is a great tool.
Yeah, it has difficulties as well. I can tell you, for when you have to treat the Percival valve afterwards.
If you have to do valve in valve.
You have to do a valve in valve. It's not the easiest thing.
Yeah.
So believe me, I've done quite a few of them. And I've seen quite a few of them being failed. All right, any of the panelists, Dr. Kontrafouris, Dr. Kogerakis, Kolokathis, Chalapas? Okay, Dr. Kolokathis. Can you have the microphone, please? Can you pass the microphone, please?
It's there in your seat.
Grigoris, congratulations for the excellent lecture. I wonder you show us this scaring video with the evolute explantation. It's also complex and difficult for a balloon expandable valve, or in this case, the procedure is easier?
Yeah. I think it's slightly easier, as I showed you from the statistics from the global registries as well. It's not just my opinion, but it's also the cardiothoracic surgery community in the world. The procedure is slightly easier because it's a shorter valve. So it's touching less of the aortic wall. That being said, it can also be difficult depending on the height of implantation as well and how long it has been, whether it has kind of incorporated and grown into the aortic root. So time is important. If you think that there's a valve that may need to be removed, the earlier you send it to a surgeon, the better. As we were saying with Dr. Michalis before, Professor Michalis, most of the explantations in these registries are occurring at around 1 year, but even 1 year is long enough for, as Dr. Chamogeorgakis said, the metallic frame of the self-expanding valve, or even the balloon expandable valve, to grow into the aortic wall. And when you remove it, as Dr. Chamogeorgakis will attest, sometimes it looks like a waffle. So it's made an imprint, and you can see the imprint that this has left behind. And to be quite honest with you, as a surgeon, sometimes you wonder about what the integrity of this wall will be. Even if you're able to remove the frame without damaging the wall, you wonder about the integrity of this aortic wall.
So all the issue is the stent?
The stent frame is the issue, yeah. The stent frame is usually the issue.
Yes, please. But that will be the last one because we've been pushed.
Thank you for the very nice speech. But in the case that you showed, the Evolute case, it was a stent frame infolding. So stent frame infolding, but it must be recognized at the time of implantation. The reason for stent frame infolding is mainly is improper loading. The second one is oversizing, and the third one is the bicuspid anatomy. Maybe one predilation first, and when we recognize stent frame infolding, in that case, that valve should be definitely removed from the body.
I agree with you 100%, and I think that the case that I showed, these may be historical cases because we may never see these cases again. Because with increasing recognition all of these things are going to happen. You know, I reviewed the TAVI literature from when TAVI first started being done, you know, more than a decade ago. And so if you look at the complications that were occurring then, valves were popping up into the ascending aorta, they were diving down, they were rupturing the apex of the LV. You know, this, fortunately, I think is soon going to belong to the past. However, there will still be other indications for removing a TAVR valve.
Some novel devices also are coming for the basilica procedures, like Picardia device and shortcut procedures.
Yeah.
So every sites are working a lot for this issue. Thank you.
100%, yeah, thank you.
Good. Thank you, Greg.